Challenges for prevention of heart disease. Welcome. I'm Carl Swedberg here at Cardiology Update in Davos. This is EHJ Today. I'm here with Professor David Wood from London. Welcome, David.
Thank you.
You have been talking about the Eurospire aspects from the Eurospire program. Now, please tell me a little about this program, because it's been running for a long time now.
Yeah, it's been running for almost 20 years, and the stimulus was the first European Society of Cardiology guidelines on prevention of coronary heart disease in clinical practice, led by Kalevi Pirila from Finland and published in 1994 in the European Heart Journal. And they defined priorities for prevention and treatment thresholds and targets, and that led naturally to the question, so how are coronary patients being managed? And that was the first Eurospire survey. And we are now in our fourth survey, just completed, and it reveals that the challenges remain large and are to some extent changing. So we see over time that the prevalence of smoking, for example, is unchanged, despite the evidence base for pharmacotherapies for smoking cessation, which are really just not being used to help our patients break this addiction. And what is particularly concerning is that the prevalence of smoking remains the same, but it is highest in the youngest patients. So those under 50, both men and women, have the highest prevalences of smoking after an acute coronary syndrome. So the potential for them to benefit in terms of reducing their risk of a recurrent event and prolonging their life expectancy is absolutely enormous.
Isn't that a disappointment then, over all these years, that we haven't been more successful?
Yeah, I think it is a disappointment, and I think the challenge for lifestyle change, delivering an effective smoking intervention, helping people to modify their diets and become more physically active, is often beyond the training and experience of cardiologists, and they need to be supported by multidisciplinary teams. They need support from dietitians and physiotherapists and so on to deliver that type of program.
So there is definitely further challenges to address this preventive programs. Now, what did you present or discuss here in particular?
Well, I showed at Davos the trends in lifestyle and risk factor management, and beyond the trends in smoking, we've seen a substantial increase in the prevalence of obesity in our patients, and also central obesity. And that to some extent mirrors the growth in obesity in the population at large. And unsurprisingly, this has led to an increasing prevalence of diabetes. And in our most recent survey, we undertook an oral glucose tolerance test in all patients with coronary disease, about a year or so after their hospitalization. And what we found was that although only about 26% reported that they had a diagnosis of diabetes, when we formally investigated them with an OGTT, we found that 66% had either dysglycemia, impaired fasting glycemia or impaired glucose tolerance, or undetected diabetes, on top of those who reported that they had a diagnosis of diabetes. So the diagnosis of coronary disease is almost synonymous with the diagnosis of dysglycemia and diabetes. And this is unrecognized, and actually we need to be more systematic in our investigation of coronary patients, because there are interventions in terms of lifestyle and glucose management which will reduce the risk of progressing to diabetes, but also reduce the risk of microvascular disease as well. So here is another challenge before us.
So what could be done for these patients at risk?
Well, I think
or these potential patients at risk.
I mean, they are all at high risk because they have already developed cardiovascular disease. But the challenge is, can we help these patients to reduce their total cardiovascular risk? And the evidence from the meta-analyses of randomized controlled trials of rehabilitation, the meta-analyses of secondary prevention are absolutely compelling. They show a reduction in all-cause mortality. So why aren't we delivering these programs? And we are not providing these programs for about 2/3 of the coronary patient population. And I think that cardiologists running busy acute services and who manage patients with acute coronary syndrome beyond the intervention, beyond the angioplasty and stenting and appropriate medical therapies, they leave the subsequent management of these patients to others. And actually, I think we have a responsibility to marry intervention with prevention. The same quality that goes into a professional intervention should be matched by the same quality in a prevention program.
Yeah, so it seems a lot more still remains to be done. Now, what about the Eurospire program in the future? Will you continue with a fifth program, or?
Yes, there is a plan for Eurospire 5 to start in 2016. That is when the next iteration of the European prevention guidelines will be published. So we will follow in its wake and see whether the new guidelines and whatever their new thresholds and treatment targets might be, whether these are being achieved in clinical practice.
Yeah, to me it seems very important to do that, having heard about all these remaining risk factors and that still so much needs to be achieved. So it's up to everyone involved in this business to do something and help out for all the potential problems we otherwise will have. Well, thank you, David, for this interesting information.
Pleasure.